Hello, I'm Hannah Morris, an educational psychologist. In this video, you'll hear from some professionals that often work with children who have special educational needs or disabilities. I'm going to explain our roles so you have a better understanding of the ways we help children when there are concerns about their learning and development. I'm going to start by explaining what educational psychologists do. Psychology is the science of understanding our minds and behaviours. Psychologists use their knowledge of research to help understand people they work with and how to help them. This includes how our brains work and affect what we do, the links between our experiences, thoughts and feelings, and the ways we learn. Educational psychologists, sometimes called EPs or EdPsychs for short, focus on understanding barriers to learning and development and what can help with any difficulties in education. EPs work in all sorts of settings, such as nurseries and schools, child and family centres, colleges and universities, the youth justice system, and hospitals. Some EPs work for local authorities, and some work independently in private practice. We often work closely with other professionals, some that you'll hear from in the other clips coming up. Educational psychologists work with children and adults of all ages, covering any type of special educational need or disability. However, we tend to choose areas of work that we develop as specialisms. I've developed particular interests in helping children who are in care, have neurodevelopmental differences such as autism and attention deficit hyperactivity disorder, ADHD, have experienced trauma or bereavement, or have specific learning difficulties, including dyslexia and dyscalculia. EdPsychs work with children and young people in different ways, but typically we gather background information, talk with parents and teaching staff, observe children in their education setting, and carry out individual assessments, including gathering the child's views. And these assessments are designed to identify children's strengths and areas for further development. Assessments might include exploring a child's abilities and skills in problem solving, processing information, and using their memory, how they develop relationships with adults and other children, their understanding of language and how they communicate, learning to read, spell, write and understand maths, their coordination and motor development, planning and being organised, as well as their understanding of emotions and how to cope with negative feelings. We then pull all the information together and use our knowledge of the psychology of teaching and learning to help with understanding what's working well for a child and what can be done to help them make progress. We think about children's learning environments and relationships with others so that we can recommend useful resources and ways that adults working with the child can adapt their teaching to enable the child to have even more of a positive learning experience. Some EPs also offer therapeutic services, carry out work as part of education, health and care plan assessments or court cases, engage in research or project work, develop resources for publication, and provide training. Educational psychologists are passionate about enabling children to thrive in education. I hope this clip has helped you understand a bit more about our role and the different ways that we work. I'd like to thank all the professionals that have contributed to this video and hope that you find their clips useful in better understanding how we all work in supporting children's learning and development.
Hello, I'm Karen Massey and I'm here from All About Speech Therapy to talk to you today about the role of the speech and language therapist. Speech and language therapists help in different areas of communication, and some speech and language therapists also complete additional training to support people with eating, drinking and swallowing. If we look at communication, there are three broad areas in which a speech and language therapist might help. The first is with means of communication. So this refers to how somebody actually communicates, whether it's through speaking, whether it's through signing, whether it's through photographs or symbols or the written word or even a high-tech communication aid. A speech and language therapist can help if somebody is having a problem with any of those means. The second area is the reasons for communication. So when somebody has the means to communicate, they also need to have a reason for communication. So a speech and language therapist can help problem solve if somebody is not greeting or commenting or requesting or responding to questions or asking questions. Lots of different reasons why we need to communicate throughout the day. The third area is called opportunities. So sometimes somebody has the means to communicate and a reason for communicating, but the opportunities are not there. And this is largely around the environment and other people. So opportunities can be created. If we think about a trip to the supermarket, in scenario A, everything is easily accessible. You know exactly where all the food is that you want to buy, and you're able to use the self-checkout at the end. You might not have an opportunity to communicate with another person, so you do it all independently. However, if you go to a supermarket you've not been to before and you don't know where everything is, and when you get to the food you want, it's too high up, so you need to ask for help, and then there are no self-checkouts, so you need to go through a checkout where there's a cashier. This scenario B would offer lots of opportunities for communication. So there are points in the day where you need to actually say something to another person in order to be able to achieve a goal. So speech therapists help in means, reasons, and opportunities for communication. And then dysphagia therapists who help with eating, drinking, and swallowing would look at if there are difficulties with a person's eating and drinking relating to the safety of their swallow. And that's when a speech and language therapist might also get involved. So there you have it, a quick whistle-stop tour of the role of the speech and language therapist.
Hi, my name is Taryn Heasley and I'm a pediatric occupational therapist. Hannah Morris, an educational psychologist, just got in touch and asked me to make a brief video about what PEDS OTs do. So basically we see a wide range of children with ASD, ADD, ADHD, non-specific learning difficulties, children with dyspraxia, or what is now known as developmental coordination disorder, children with cerebral palsy, Down syndrome, as well as sensory processing disorders. OTs work closely with speech and language therapists, physios, educational psychologists, pediatricians, and social workers. We can also work in a variety of settings, so we can be in private clinics, in community-based clinics, we can be in schools or hospitals. OTs, like any other healthcare professionals, can specialize. So you'll get PEDS OTs who specialize in physical disabilities, with a big focus being on seating, perhaps, on equipment, major adaptations in the home. You'll get OTs who specialize in mental health, emotional behaviors, eating disorders, and you'll get OTs who specialize in sensory integration. In terms of what PEDS OTs are interested in, we are interested in functional independence. Can this child eat, dress, feed themselves, manage their own toileting? What is happening around their learning? Specifically looking at fine motor skills, shoulder stability, core strength and posture, functional vision. How do they use their two hands together? What's their midline like? So lots of focus on those kinds of things, especially when you're in school. We're looking at handwriting, visual perception, visual motor integration, what might be impacting on this child's ability to be independent or to learn to their best potential. Does emotional behavior impact on this? Does sensory processing impact on this? So we're able to do a very thorough assessment of your child using both standardized and non-standardized assessments. And we use a lot of clinical observations and in-depth discussion with your child, with you guys as parents, and anybody else who's involved in the child. So teachers, one-to-ones, physio, speech and language therapists. I hope that you found this video useful in terms of understanding what PEDS OTs do. And obviously, if you've got any concerns about your child, or you want to just discuss your child's needs with me, do get in touch with me via email. And I hope you've enjoyed this video. Thank you for listening.
Hello, I'm Dr. Ian Takon. I'm a neurodevelopmental pediatrician. Neurodevelopmental pediatricians are child specialists who have done additional training in the field of child development. They're primarily pediatricians who've gone through pediatric postgraduate training and in their last few years have specialized in developmental pediatrics. Developmental pediatricians see children with a wide range of disorders. This includes children with developmental delay, children with physical disabilities, children with delay in their speech and language skills, children with social communication concerns, including children with some developmental and behavioral concerns that might be suggestive of certain disorders like ADHD or autism spectrum disorder. Developmental pediatricians tend to work with other professionals such as psychologists, physiotherapists, occupational therapists, speech and language therapists, as they do sometimes need to refer the children to see these professionals whilst trying to explore the nature of this child's difficulties. When developmental pediatricians see the children, they obtain a history from the parents. They get a detailed history to understand the birth history, the early development, and they also obtain information from schools. They then interact with the children and sometimes carry out structured assessment to determine the level of the child's development. The pediatricians may sometimes request for investigations depending on the nature of the child's problems. The investigations could sometimes include blood investigations or scans or x-rays. When the pediatrician gets all the information, they summarize them and analyze the information to determine the underlying cause of the child's difficulties and also to decide whether the child's development fits into any particular pattern. In my job as a developmental pediatrician, I see lots of children with various conditions, and some of these include children with ADHD, autism spectrum disorder, dyspraxia, cerebral palsy, tic disorders. I hope this help clarifies my role as a developmental pediatrician. Thank you.
Hello, my name is Melanie and I am a children's physiotherapist. I have over 20 years' experience of working as a paediatric physiotherapist in both the NHS and private sector. Physiotherapy is a profession that works with people to identify and maximise their ability to move and function, an essential part of what it means to be healthy. This means that physiotherapists play a key role in enabling people to improve their health, well-being and quality of life. Paediatric physiotherapy is the treatment and care of babies, children and young people from birth to 19 years. Physiotherapists who work with children are specialist practitioners who have the right skills and knowledge to deliver appropriate care and education to encourage family involvement. They have additional expert knowledge and experience of child development and of childhood conditions. Children's physiotherapists work in many different settings, including hospitals, clinics, schools, children's homes, hydrotherapy pools, sports centres, and in fact pretty much anywhere that children go. This is because the aim of physiotherapy is to help children participate in activities to the best of their ability, no matter what their disability may be. We adapt our approach and treatment to the individual children we see. This is often dependent on a child's age, diagnosis, and their motivation. We recognise the importance of working in partnership with children, parents and carers, and the wider team to maximise a child's physical abilities and independence. I never stop learning from the children I treat, and am constantly reminded of their resilience and determination to succeed, often in the face of extreme difficulties. Every day in my work is different, bringing so many wonderful challenges, opportunities, fun and rewards for the children I see. I am so fortunate and grateful to be in the career I am and to be able to have such an important role in contributing towards children's goals, achievements and successes.
Hello, my name's Josephine Marriage. I'm an audiologist and I'm director of CHEER. CHEER is an independent centre for children's hearing management. We offer hearing testing for children using behavioural testing from around 6 months of age. We aim to test each ear separately and derive ear-specific hearing levels. We aim to derive functional testing to look at speech tests for children from around 2 years of age. This will be through live voice presentation and then using pre-recorded words or a computer-generated speech test where the child touches the screen to choose their response. We have some objective hearing tests, including tympanometry to look for middle ear problems and otoacoustic emissions. And these are part of the test battery to build a comprehensive picture of children's hearing. We aim to look at functional listening in children as they get to school age, and this may be through their listening skills or auditory processing skills, and we would consider options for intervening to either build those skills through treatment programs or perhaps by using technology to help to facilitate hearing in the classroom.
Hello, my name's Elliot Benjamin. I'm an ear, nose and throat surgeon or an otorhinolaryngologist. Our specialty covers all aspects of life, from antenatal diagnosis of maybe airway complications, looking after newborn babies, all the way up to hearing loss in the elderly. We very much get involved with early childhood developmental problems, such as things that may affect their hearing, their speech and language development. One of the most common things we see is blue ear, where children present with maybe slight reduction in their pronunciation or vocabulary, and actually have the cause for this will be some slight hearing loss because of a build-up of fluid behind their ear called glue ear, which may need either medical or surgical treatment. Sometimes we pick up sensory neural, i.e. nerve-related hearing loss. We also see lots of children who have excessive snoring, verging on sleep-disordered breathing or sleep apnea, which may present itself with children who wake up constantly at night, have very poor sleep patterns, and have a degree of daytime somnolence, i.e. daytime sleepiness, and are unable to perform in a normal way compared to their peers. ENT has a lot to offer to help these children in various different aspects. And if anyone would like to contact me for further information, they can contact me on my website, which is www.earnosethroatlondon.com, or you can contact my secretary on 07891 599 395 or on her email info@earnosethroatlondon.com. Thank you very much.
Hi, I'm Laura and I am the director and owner of the Butterfly Room Therapy Services in Stevenage. Children and individuals with neurodevelopmental disorders such as autism and ADHD have a high prevalent rate of having a comorbid mental health condition. Recent statistics show that an individual with autism or ADHD is around 90% likely to have a comorbid mental health condition. This can include anxiety disorders, depression, eating disorders, self-harming behaviours, and a range of other difficulties. Children and individuals with autism often have trouble recognising their emotions and identifying what those mean. Recent research shows that girls on the spectrum do not recognise anxiety as a separate emotion. They feel that it is central to them and cannot distinguish between when they are anxious and when they are not. which can often lead to internalising behaviours, self-harming behaviours, and so on and so on. So it is really important that individuals with neurodevelopmental disorders such as autism and ADHD are able to access appropriate mental health support. Research additionally shows that there are many barriers to accessing mental health support for those in the spectrum or with ADHD, including a range of different factors, including support not being tailored, lack of understanding of autism and ADHD, obviously extremely large waiting lists, and environments that are not user-friendly for this population. So it's really important to ensure that there is somewhere that is safe and that is tailored with mental health professionals that are understanding and are also trained in neurodevelopmental disorders, which is what we at the Butterfly Room do. We offer a range of different therapies, including art therapy, drama therapy, play therapy, music therapy, adapted CBT, and counselling for individuals on the spectrum or with ADHD, using our experience as mental health professionals alongside lived and additional training in autistic spectrum disorders and ADHD to ensure that we are providing a tailored support package with a strong therapeutic alliance, and also a multidisciplinary approach so that we are including families and other agencies to ensure that everybody is all working together to support our children.
Clinical psychologists are trained to work with people of all ages with a wide variety of mental health difficulties. So this could include depression, anxiety, panic, obsessive compulsive disorder, eating disorders, and many more. We're taught how to listen to people with empathy and without judgment so that people can feel comfortable talking to us about all aspects of their personal lives. We help people make sense of what's going on, understand why these things might be happening to them, and most importantly, if they want to help them learn how to overcome things. So we can use a range of therapeutic approaches to help people effectively manage and make differences in their lives. And research shows that clinical psychologists really can help people make improvements. If you need to see a clinical psychologist, then the best person to consult first is your GP, who will probably refer you to NHS services. But if you wanted to see a clinical psychologist privately, which can sometimes be a bit quicker, then please do look for a registered therapist on the British Psychological Society website or with the HCPC.
Hello. I'm Paul Adler. I'm an optometrist with a special interest in vision and learning. Many of my patients don't need glasses, but most of them come with some difficulties or concerns about their vision, or sometimes just to rule out a visual problem. Many of the difficulties include blurry vision that hasn't been diagnosed, and sometimes people have visual processing or visual perceptual problems. Examples of these may be blurry vision or double vision, particularly after prolonged periods. Typically this takes anything from a minute or two to 10 or 15 minutes and can be quite debilitating, cause loss of concentration and fidgetiness and quite a lot of visual discomfort. But it prevents people from being able to learn for any length of time. Other people, and often associated with this, complain of words that appear to move on the page. So it can be very distracting to find that the words have disappeared before you can read them, and sometimes the gaps will disappear between words. This is particularly awkward if words merge, because finding the beginning of one word and the end of the next can be very difficult. And this leads to tracking difficulties, loss of place. People frequently tell me that they miss several words at a time, sometimes make inappropriate substitutions. Some people, they drop lines from one sentence to the next and maybe 2 or 3 lines at a time and then pop back. And this causes difficulty in reading the words in the right order, and of course it then really doesn't make much sense at all. Sometimes people tell me that words appear to drop off the end of the page, and again that's pretty debilitating when it comes to being able to understand what what the author intended in the text. One of the most often brought problems are people who complain that the brightness of the page is really too much for them to cope with, and it hurts for them to look. This is often accompanied by the appearance of rivers running down the page. Sometimes it's as if the background brightness or the white colouring of the page is just causing huge amounts of glare, and the shimmering, sort of flowing river finds its way between all the gaps in the words from top of the page to the bottom. This is extremely hard work for patients to cope with, and frequently leads to red eyes, sore eyes, watery vision, and excessive blinking. Patients are very frequently fidgety and discomforted, and you can get lots of people who complain with headaches on reading as well. Dealing with these difficulties can be quite exhausting. So one of the complaints many patients have is that they're very tired at the end of the day and they don't seem to be able to cope in the afternoons. The effort can be so much in some patients, particularly those who are trying to be good students, that they put in excessive amount of focusing effort. And this means that when they look up at the board after close work, they very frequently complain of blurry vision. And that makes copying rather slow or rather difficult. And so if you have to copy down your homework, then that is extremely difficult. When you get it home, it doesn't make much sense. And it also has a knock-on effect with handwriting. So pencil grip can be quite tight and the upper body can be very tense when people read. A visual assessment really concentrates on understanding what the problem is that the person has and addresses that problem by trying to work out what if any, techniques can be used to help them. So we often give people eye exercises in the way of vision therapy. That can be for tracking or for eye muscle problems, but we also frequently give coloured overlays, often as a diagnostic tool with a view to getting a precision tinted lens in a pair of spectacles. Sometimes, even though you don't need glasses for seeing, we'll give stress relieving lenses for either reading or for all the time. And sometimes we use a combination of all of those things. So if you'd like more information, you can go to our website, but we also have a series of leaflets that we can send you if you'd just like to call and ask one of our receptionists to send you those in the post. And if you have any other questions, we'd be very happy to hear from you. Give us a call and we'll try and answer your questions.
Hi, I'm Dr. Joshua Westbury and I'm a consultant child and adolescent psychiatrist. A psychiatrist is a medical doctor specialising in the assessment and treatment of mental illness. Psychiatrists start at medical school and qualify as doctors, then they train in general psychiatry and then in a subspecialty such as child and adolescent psychiatry before becoming a consultant. In my specialty, I work mainly with school-aged children and young people from ages about 5 to 18 and with their families. Psychiatrists often work as part of community mental health teams such as CAMHS or UMS teams in the NHS, but they can also work independently. I currently have an NHS role as the consultant for an adolescent inpatient service, and I also see outpatients through private clinics. My role includes meeting with a young person and their family to try to understand the nature of their concerns and to see whether there might be any mental health issues present. For example, depression, anxiety disorders such as phobias, obsessive-compulsive disorder or post-traumatic stress disorder, ADHD, eating disorders, autistic spectrum disorders, and some other mental health issues. I'm also looking out for other kinds of medical issues that might be present. For example, anemia or underactive thyroid can both cause symptoms a lot like depression. It's also true that young people might experience low mood, anxiety or other difficulties for reasons that aren't to do with mental illness at all, and part of my role is to help rule out mental illness when it's not present. Psychiatrists often work alongside psychologists, psychotherapists and other healthcare professionals. In some of our work, for example carrying out assessments for autistic spectrum disorders, this is usually carried out by different professionals working together. Based on the diagnosis and other information from the assessment, I can provide advice on how to help a young person recover from or manage their mental health difficulties and how a family can help or support them. This advice might relate to lifestyle changes that can make a difference to mental health, such as exercise, diet, sleep, and stress management in general. I can also advise on whether psychological therapy might be helpful and on different types of therapy. In my case, although I've had some training and experience with individual and group therapy, I'm not a qualified psychotherapist myself, but I might be able to help you find or choose a therapist that can help you or your child. Some psychiatrists do take on extra training so that they can offer therapy as well. Part of my role is to advise on the use of medication and to prescribe medication in the few situations where this is needed. For example, depression or anxiety disorders should be managed with psychological therapy if they're not too severe. In the most severe cases, very occasionally they might need treatment with antidepressants as well. Medication is also often important in the management of ADHD and in some other mental health issues. If prescribing, then I would usually carry out follow-up appointments to see whether treatment is making a difference or whether changes need to be made. If there are side effects from medication, I can advise on how to manage them. I can also help decide when to stop medication. My role is never to persuade or pressure young people or families into taking up a particular treatment, but to answer your questions and support you and your child in making informed choices for yourselves.
Hello, my name's Dr. Tammy Headley. I'm a consultant paediatric neurologist. A neurologist we're trained through a medical model really. So how we work is to meet the family and child who presents with a problem and try and work out the story behind that presenting complaint. Usually that involves learning a little bit about the child's birth history, the developmental history and the wider family history, and then putting that together with the story around the current problem. I emphasise that because sometimes the presenting problem isn't always the full story, and it's important to then ask some targeted questions to try and work out if there's any other co-occurring conditions that might be important for that child. For example, their learning in school or their friendships. We then put that together with a full neurological and general systematic examination. Often the children come to us from a paediatrician and they will have had some of those investigations and examinations already. But we would then look at the neurology system in some detail, examining the cranial nerves, the muscles, the gait examination, the strength within the nerves and muscles and the power and the way the child walks, for example, looking at their back and things. We'd then decide if any investigations were necessary, and we'd formulate a management plan for the presumed diagnosis, if there is one, or we would use a sort of access to define the current problems. I work in a Tourette clinic, and when we meet children with tics, for example, the tics may be the presenting complaint, but there might be some other co-occurring conditions that are more problematic for the child or family. So, for example, social anxiety, friendship problems, or specific learning problems or attentional difficulties. So it would be our job to explore those other things and try and define them and work out if any of the difficulties needed any specific interventions. Neurologists work with a range of other professionals. We tend to work very closely with paediatricians, with psychologists and the psychiatrists, with the nursing teams, and then with the wider multidisciplinary team, the OT, occupational therapist, the physiotherapist and the speech and language team. We work together with dietitians and a range of other people as well, and then communicate directly with the paediatricians and general practitioners to help support the child. Within the Tourette service, we would expect to work closely with psychologists, sometimes with CAMS services and with community paediatricians. And we would often help work to devise a plan for the family and then help share care across different teams. It would also be quite important to investigate for co-occurring conditions where necessary. So exploring, for example, autoimmunity, infectious disease, looking for space-occupying lesions or evidence of trauma or vascular pathology. And there's a range of other things that we would explore if we met a child with a presenting problem. So if you saw someone with epilepsy, for example, you'd want to be able to come up with a presumed diagnosis for the cause of the epilepsy, whether it's a genetic thing or a acquired problem. I hope that helps.
Hi, so my name's Curtis. I'm a social worker and I work in the adolescence team, and we are primarily a safeguarding team, and I work with a couple of other teams directly. We work with GPs and schools and so forth. What we try to do when we're working with families and children and parents is try to establish whether the child is safe. That's the priority, because if we don't have safety, we don't have anything really. And once we work out how safe a child is, then we have a safety or risk assessment to kind of establish, well, if things take a turn for the worst, how can we manage the situation? And it has to be done in every case so that people can feel safe or feel that they have the tools to be safe. In order to do that, we have to capture the voice of both the young person and the parent. We have to understand how they feel safe, and that's really going to give context to the concept or the perception of safety. So we can say stay at home, but staying at home doesn't necessarily make you feel safe, and we find that a lot in our work. So we have to understand how the young person and or the family feels safe so that we can make them feel safe, and maybe they have a better understanding of what safety is for them more than we do. And what we'll do when we have completed our assessment is we will refer to services. Some of them we have on hand, or some of them we have to explore, that are in the community, services that might be able to help them. Primarily, for example, if a young person is struggling with education or not attending school, then what we will do is we might refer them to a service in-house that can put them onto an educational program that more suits them, because sometimes schools are unable to meet the needs of the young person. Other, like for example, an apprenticeship, which is more suited to what we're finding a lot more young boys, to help them grow in what they feel strong in. What we try to do is avoid exclusion, so we'll have professionals meetings or core group meetings, whatever they might be, to really help pull together the minds in play so that the young person can get everybody on board on the same page and working for the same cause. That's it.
Hello, my name is Lynn McCann and I'm an autism specialist teacher. My job is to work alongside SENCOs, teachers and teaching assistants to help them understand the needs of the autistic children in their class. I work independently, but local authorities and special schools can also provide specialist or advisory teachers. Sometimes they're called outreach teachers. A specialist teacher usually has a specialism in one or two areas. You can have specialist teachers of the deaf, visually impaired, dyslexia, dyspraxia, ADHD, for example. School SENCOs will usually ask a specialist teacher to help with the assessment, the planning and the support in class for a pupil with any specific needs. They sometimes can get this free from their local authority, but often it's a service they will have to pay for. The local authority, the specialist outreach teacher or an independent specialist will usually agree a set amount of visits or regular support over a year. Schools use specialist teachers when they need that extra expertise to help them support a child. And sometimes this is already part of a child's EHCP, that a specialist teacher should help them so many hours a term. As an autism specialist, I'm sometimes asked to help gather information towards an autism diagnosis because I'm more experienced in what evidence to look for. A dyslexia specialist teacher would be able to do a screening test for dyslexia diagnosis. Most specialist teachers provide an overview of the child's needs through observing them in class, talking or playing with the child, and talking to parents and teachers. We gather all this information together and provide advice on how best to support the child in the classroom. Specialist teachers tend to focus on the practical strategies and resources that the teacher can use and that will take away some of those barriers to learning for the child. We might also suggest support for social and emotional and well-being, as well as do one-to-one work with the child and advise on things like transitions. A specialist teacher can write reports for education, health and care plan applications and attend annual reviews. As a specialist teacher, I try to help the school, parents and child by visiting each half term and helping the support for the child always stay relevant, and we build up on what we've achieved so far. We love the long-term relationships we can build up. We're always learning about our specialist area too, so that we can offer relevant training to schools. Many specialist teachers do provide training for schools and parents as well as visiting their pupils.
Hi there, I'm an SEN advocate and I support families nationally with EHC plan disputes and every kind of EHC plan issues that come out. I help navigate the process through supporting families through a very sort of complex maze of EHC plan issues and challenges they experience with local authority. Advocates often have to push for the legal rights under the Children and Families Act 2014 and just advocating for the rights of children in order to ensure that they have the legally secure education that's appropriate to meet their special needs. Very often advocacy can lead to tribunal appeals where situations involve supporting parents, challenging refusal to assess, refusal to issue an EHC plan, contents of the EHC plan, about therapy provision, one-to-one support, and about the type of school that's required to meet the child's needs. So very often advocates are involved in that kind of scenario in supporting parents with those challenging situations. Sometimes there's a breakdown of communication with the local authority, or sometimes simply the parents are sort of frustrated with the process and they turn to advocates to help move the case along. Parental win rate is very high for tribunals. It's around 89%. So it's often it's a very popular means and mechanism to support and ensure that a child with special needs is actually given the support that they're legally entitled to, especially more important in this climate where there's budget challenges and really sometimes local authorities often make unlawful decisions, and parents then have to get people like myself, an advocate, involved. I support families right across across England and Wales, different kind of scenarios involving EHC plans and statements. So happy to always advise and support any parent who wants to reach out to me. Okay.